Hi, this is Elliot Fishman, and welcome to our latest series of talks, and this is going to be on the adrenal gland. In the past year, I've done several additional talks on the adrenal gland, one focused on kind of the incidental adrenal lesion, the smaller ones, the adenomas versus other tumors. We spoke about some of the ways we distinguish and diagnose adenomas, the success of CT, and also spoke about some of the various other tumors. We also had a talk on large adrenal masses, with large being 4 centimeters, and I spoke about some of the challenges we have, particularly in distinguishing. We always worry about malignancy like adrenal cortical carcinoma from other lesions. And again, this 4 centimeter size is what people typically call large adrenal masses. In my experience at Hopkins, we have a multidisciplinary conference every other Friday morning at 7:30. And invariably, there are always a couple cases out of the 5 to 7 we look at that are super challenging. Other cases, probably adenomas or pheochromocytomas or obvious ACCs or other things that are very obvious. But there are always a couple cases which really challenge me and challenge all of us to try to come up with a diagnosis and how to manage the patient. So what I'm going to do in this talk, and it's going to be a multi-part talk, is go through some of the challenges we have, cover some of the various lesions, how I think about the lesions, how I can feel comfortable making the diagnosis, and what happens if I have a differential diagnosis. When do we do biopsy? When do we do follow-up? When do we do surgery? So it's really going to be a very, very practical approach, but we're going to look at a lot of cases. I have a lot of examples, and we're going to look at a wide range of pathologies. And of course, these are only going to be in adult patients. We're not looking at adrenal masses in children, which neuroblastomas, what we think about, hemorrhage, particularly in the younger age, including post-delivery hemorrhage or trauma. We're going to speak about only large masses, and we're going to leave out trauma in this discussion. Now, there was a recent article that made the point that 4 cm is a critical number. Here was the question: which size threshold has the best diagnostic performance in detecting malignancy in incidental adrenal lesions? And the article basically used 4 centimeters. Systematic review and analysis of studies evaluating greater 10 patients, evaluating the accuracy of imaging size thresholds for detecting malignancy in patients with incidental adrenal lesions and no prior history of cancer. In those studies, a size threshold over 4 centimeters demonstrated less sensitivity than that below 4 centimeters. And when you're below 4 centimeters, size thresholds achieved high sensitivity, but specificity values were lower than the 4 centimeters. So again, 4 cm seems to be magic. Remember, when we talk about washout values of 60% for adenomas, we always say the lesion has to be 4 centimeters or less. You remember people used to say 3 centimeters, but it's really 4 centimeters. In this article that I'm referring to recently by Wilson, a 4 cm threshold demonstrates the highest combined sensitivity and specificity, with a preserved specificity compared with higher size thresholds, but with a trend toward improved sensitivity. Further research into 4 to 5 centimeter lesions will need to be done. But right now, 4 tends to be a very magic number. Now, one of the challenges, of course, is in managing patients, there are many different guidelines. The ACC recommends consideration of resection for incidental adrenal lesions over 4 centimeters without definite benign features, with no prior history of cancer and no biochemical evidence of PHEOs. However, the European guidelines do not use a size threshold, but they look at function. So we look at things in different ways in the U.S. guidelines, and the truth is that's the ACR guidelines. The endocrine societies in the U.S. are much closer to Europe, and we'll talk a little bit about that as we go along. Now, you can see on this list, over 4 cm, typically you're going to be worried about adrenal cortical carcinoma, okay? But we see very few of those cases in reality. When you think about it, even though a mass is over 4 cm, it could be benign. It could be an adenoma, maybe a hematoma. It could be a cyst. It could be a myelolipoma. It could be a lymphangioma. It could be a pheochromocytoma, though 10% of them are going to be malignant. It could be that ACC. It could be METS, melanoma, hepatoma, renal cell are all things we consider. It could be primary lymphoma and occasionally unusual sarcomas. Now, one of the things to remember is when people talk about incidental masses over 4 cm, they do make the point that the patient has no known malignancy. When you have a known malignancy, like a renal cell or a hepatoma or melanoma, the likelihood increases significantly, even without looking at the images, that the lesion is going to be metastatic. It's not always. Obviously, you can have cysts, you can have pheos, you can have adenomas in patients with malignancies, but invariably, it's a high chance you're going to have something that's going to be metastatic. Now, the unique challenge of large masses is you don't want to do biopsies. I'm going to speak about that in a moment. The reason we do biopsies typically is a patient with a known primary and you see an adrenal lesion and you're not sure if it's metastatic or not, let's say melanoma, and the presence of metastasis will change the therapy. Then you'll biopsy it. But typically, in other cases, you don't want to do biopsies. For example, if something could be an adrenal cortical carcinoma, you want to do an open surgical procedure. The only way is to have clear margins. Once you biopsy something, you're going to seed. It's the same reason why, even if you think about an ACC, even though laparoscopic surgery, patients recover faster, in order to get all the nodes out, in order to get the mass out as one big mass, you need to do an open procedure and not do laparoscopic surgery. Now, one of the things we'll also talk about, and we talk about with incidental adrenal lesions, is also lab values. Lab values can point to, for example, pheochromocytoma. Lab values can point to aldosteronoma. Lab values can point to Cushing's, which then makes you think about an ACC. So lab values are very important, and how we work that in becomes very, very important. Now, in terms of adrenal biopsies, interestingly, there's been a few articles this year. In this article by Krishna, the purpose of our study was to evaluate the utility of adrenal biopsies in patients without known or suspected extraadrenal primary malignancy. And in that scenario, adrenal mass biopsy had a low diagnostic yield, low sensitivity, and low specificity for malignancy. A biopsy of adrenal cortical neoplasm did not reliably distinguish between benign and malignant masses. And so the impact and the conclusion is biopsy appears to have limited utility for the evaluation of incidental adrenal masses in patients without a known primary. Very, very important. That article goes on making the point when diagnostic adrenal mass biopsy had high sensitivity and specificity for malignancy. However, biopsy had a high non-diagnostic rate, and when classifying non-diagnostic biopsies as false results, had low sensitivity and specificity for malignancy. And even when you're thinking about an ACC, with biopsy, often you couldn't distinguish between benign and adrenal masses. Another article by Maloney looking at patients again without extraadrenal malignancies found that biopsies had a low diagnostic yield, low sensitivity, and low specificity, and again recommended against biopsies. And as I mentioned, in our practice, this is what we believe as well. The other thing the endocrine folks and the endocrine surgeons, as I mentioned, speak about, if it is an ACC, you're taking the only chance at the patient's survival, which is clear margins at surgery once you do a biopsy. So biopsies are good if you have a known primary and you're looking to confirm metastasis, which may change therapy. But if you're not going to do that, then it's not worth doing the biopsy, and the negatives outweigh the positives. In this article by Yip with guidelines for adrenalectomy, they also, is interesting, prevalence of ACC in incidentally discovered nodules is less than 0.5% for smaller than 4 cm nodules, 5% for nodules 4 to 6, and up to 35% for nodules over 6. Metastatic disease to the adrenal can be identified in 1 to 3% of patients without a history of malignancy, and up to 8% in the patients with a history of malignancy. Other features in addition to size should be considered when assessing risk of either a primary or secondary malignancy. So one of the things they speak about is adrenalectomies. Even adrenalectomy, you really need to think about what you're dealing with the reality being that most adrenal lesions are going to be benign. Now, we will admit that at times we will resect lesions because we worry about them and they end up being benign, and that's great for the patient. Obviously, they would have preferred not to have surgery, but surely if you think the lesion probably isn't malignant and probably isn't an ACC, you can do laparoscopic surgery and the patients do well. It's also important to realize there are some benign lesions, like an adrenal myelolipoma, that most people will recommend above 5 cm to resect, because those lesions, even though they're asymptomatic now, can potentially bleed, and that can be very problematic. So I think one of the interesting things at sitting at conference is learning how the adrenal science of surgery and biopsy is changing, but it's more conservative, and also the limitations of what we understand. Now, I mentioned this talk is only going to be about 4 centimeter masses, but let me break my rule and show you 2 cases. And these cases to me are kind of a warning, and I like to show them because it also makes the point about following rules. If you look at this case, there's an incidental lesion. This patient had hypertension, so maybe that's not incidental, but they were getting a CT for, I think, a stone protocol, and you see a 1 centimeter plus lesion in the right adrenal gland. Not very impressive. There it is. And when you give contrast, it does enhance to about 100. And when you look at its washout, it doesn't wash out significantly, but again, it's a small little lesion. And you look at it and you say, this doesn't seem to be very, very important. But it ended up, as the patient was worked up with lab values, it was primary hyperaldosteronism, okay? And the presentation is classically known to occur in a patient with hypertension and hypokalemia. So that's great. When you have primary aldo, you go in there, resect the lesion, you cure the patient. Most of these are going to be adenomas. But if you look at the list, adrenal cortical carcinoma can present with increased aldosterone producing tumors. And in fact, in this case, it was a 14 millimeter adrenal cortical carcinoma. Now, it's amazing the importance of following the rules. Now, the good news for the patient, the tumor was encapsulated, there was no extension outside, and the patient is just being watched. But we talk about adrenal cortical carcinoma being large. Here was 14 millimeters. This patient had symptoms, a female with increased facial hair. You worried about some hormonal issue. You see a relatively innocuous right adrenal lesion, which measures about 36 Hounsfield units on the non-contrast scans, and then enhances to about 100. And then when you look at the washout is 53, which means that basically your washout is over 60%. And this would mean it's an adenoma. But the patient has functional symptoms because they have too much facial hair in a female. And so you can't use the values. Now, the washout of 60%, we always talk about how if a lesion enhances above 110 or 120, then it's likely a FEO, and FEOs do have a fast washout value, so you can be confused there. But here, nothing gets above 100, and the washout is over 60%. But it makes the point that when patients have symptoms, in this case excessive hair, you got to worry about a tumor. And this was resected as well, and this was a 1 centimeter adrenal cortical carcinoma. Again, it looks like an adenoma to all of us looking at this image, but it wasn't. So that's my kind of rule breakers to make the point that size alone is not critical, that I think radiologists need to pay more attention to function, and I think we are doing that, particularly in multidisciplinary conference. Now, we always think when something gets large in the adrenal that it's going to be malignant. But this was a very good article looking at a large group of patients. This was from the Mayo Clinic, looking at what happens when you have a mass in a large series above 4 centimeters. Now, what was shown was older age, male, non-incidental mode of discovery, like you have back pain or functional problems, larger size, and higher unenhanced CT attenuation value were associated with an increased risk for malignancy. Now, in the 4,085 patients with adrenal tumors above, when you looked at them, 705 had masses measuring 4 cm or more. So of all the patients referred to them, and of course this is the Mayo Clinic, so it's definitely a tertiary referral place. So basically 1 in roughly 6 of the tumors they saw was over 6 centimeters. You can see the mean age, more than half were women. But if you look, 31% were adenomas, benign lesions. Pheos were 22%, and we usually can recognize pheos. Other benign lesions were 16%. Adrenal cortical carcinoma was 13%, and other malignancies 18%. So above 4 centimeters, only a third of the lesions were actually malignant. And so the authors make the point, we suggest that clinical context, hormonal assessment, and image phenotype together can determine the need for adrenalectomy in patients with 4 centimeter lesions. And again, the importance of a multidisciplinary team, because it's very easy to say, take the lesion out, but there are complications. Patients with an open adrenalectomy are in the hospital for better than a week. The recovery time is long. So it's not the simplest thing in the world. Now, as I mentioned, malignant tumors were less frequently diagnosed incidentally. They were larger, had higher unenhanced CT values. That's the first time I've ever seen that discussed. But, I think it's the sense the differential is because a lot of the lesions in this series were adenomas, a third of them, so they typically measure under 10 Hounsfield units. So I think that pushed the number downward. Older age, male sex, non-incidental mode of discovery. So again, the history is important in helping us think about individual lesions. Now, there was an article by Thomas et al., Intra-Observer Agreement in Distinguishing Large Adrenal Adenomas and Cortical Adrenal Carcinomas on CT. And what they found was CT has the ability to consistently identify characteristics correlated with benign versus malignant tumors. And I think that indeed is the point. I think when something is aggressive looking, when you have a big mass where it has lots of vascularity and it's necrotic and it's irregular shaped, then I'm thinking about ACC. When something is perfectly round, homogeneous, regardless of the size, I'm thinking adenoma. But it's not always going to be that easy because many of the adenomas we see that are larger have had prior bleeding, for example. And so it is somewhat of a challenge. And again, CT characteristics with benign lesions included round shape, overall radiology impression of a benign lesion, the presence of fat, and a pre-contrast of less than 10. The latter two of these characteristics were highly specific for benign lesions. Right, presence of fat means you have a myelolipoma or an adenoma. Occasionally you can have fat and adrenal cortical carcinoma, but that's more because the perinephric fat is invaded and the patient's mass is going to be very, very aggressive. Now, when you speak about large masses, one other thing I should mention, because we've seen this problem before, is sometimes when you have masses, particularly on the left side, it's really hard to be certain if it's adrenal or maybe it's pancreas or spleen or a GIST tumor from the stomach or it's some primary retroperitoneal tumor. This patient had a chest CT and there was a mass, which you can see. And this was read as a big adrenal mass, and I could see why. Now, of course, there's no contrast, and this was the lowest scan because it was a chest CT. When you give IV contrast, you can see the mass is in close relationship to the stomach. You also can see that the adrenal is simply abutting the patient's tumor. And when you look at this with cinematic, you can see that it's coming off the stomach, and this was a gastric GIST tumor. Or in this case, could this be a complex cystic carcinoma or a lymphangioma or some other adrenal lesion? I would say it's definitely a possibility, but could this be a large pancreatic mass? And this ended up being a mucinous cystic neoplasm of the pancreas, which are classic for multiple septations. This is about the largest MCN I've ever seen, so that made it more challenging. And yes, we try to look for the adrenal, but when you have a large enough mass, it's hard to find the adrenal, and then you're not certain is the lesion pushing on the adrenal or simply coming off the adrenal. And here's a case we had recently, which again was sent to us probably as a benign cyst of the left adrenal gland, non-contrast appearance, well-defined. Maybe there's like a little septation, an additional cyst off the primary cystic lesion, but it's water density. So to me, I'm thinking about a simple cyst. I'm thinking if that's not the right answer, it's a lymphangioma. So I'm thinking benign. The patient had some symptoms and the size was pretty large. And you could see it kind of abuts the adrenal gland, but we thought maybe it was coming off. Well, this patient went to surgery, had it done laparoscopically, and maybe to our surprise, but not 100% to our surprise, it was actually simply a lymphangioma or a foregut duplication cyst. Those were the two things we had thought about, and this was a foregut duplication cyst. So making the point, I think, that you can't always be certain what you're going to be dealing with, but sometimes it's not going to be adrenal. Now, in terms of imaging, I think one of the things we'll speak about is 3D imaging in the evaluation of adrenal lesions, particularly with cinematic rendering. We like to talk about new things in terms of imaging. I think particularly in larger lesions, the 3D can be valuable localizing the lesion to the adrenal. It can be valuable in looking at interfaces, looking at texture. It also can be valuable if you're planning surgery. And when you think about it, we are looking at a number of different possibilities with cinematic rendering. I'll speak later about lymphoma, how lymphoma has somewhat of a classic appearance. We'll talk about things like ACC and how cinematic rendering gives you a better feel about vascular involvement. But again, perhaps we're going to learn more about adrenal lesions by looking at their 3D. And cinematic rendering has demonstrated potential to improve characterization and treatment planning of adrenal lesions at our institution. But there are several limitations. There is some overlap. There is some user learning process, and it does take a little bit of time, but I think it's well worth it. And again, you should read the article. As cinematic rendering technology becomes more widely available, it's likely to play an increasing important role in the diagnostic and treatment planning. So we mentioned all of these lesions and the fact cinematic rendering can be used in any of these lesions, but let's do this. Let's take a break right here. Let's come back in a few minutes and let's start looking a little bit closer at the various lesions. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.